Greetings. My name is Dumiso from Success Capital, and I welcome you to this short dialogue on universal health coverage, noting that it is quite a significant year. 5 years post the political declaration of 2019, where universal health coverage was a commitment made by different member states of the United Nations. And September 2023 gives us an opportunity to not only review and reflect on the progress or lack thereof that has been made, but also more importantly, on being able to accelerate where there might be needs for additional work and ensuring that we're able to fulfill Agenda 2030 whilst ensuring universal health coverage. And so, just so we get the basics right, I will give the World Health Organization's definition of universal health coverage, meaning that all people have access to the full range of quality health services that they need, when and where they need them, without financial hardship. It covers the full continuum of health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. Every country has a different path to achieving UHC and deciding what to cover based on the needs of the country's people and the resources at hand. However, the importance of access to health services and information as a basic human right is universal. To make health for all a reality, all people must have access to high-quality services for their health and the health of their families and communities. To do so, skilled health workers providing quality, people-centered care, and policymakers committed to investing in universal health coverage are essential. UHC requires strong, people-centered primary health care, good health systems which are roofed in the communities that they served. The focus should not only be in preventing and treating disease and illness, but also on helping to improve well-being and quality of life. And so I am hoping with my esteemed panelists today, we're able to unpack, this definition within Botswana's context and hopefully illuminate some of the issues where there might be a need for a little bit more progress, strengthening, and more importantly, recommend some tangible steps that we can towards fulfilling the right to health. And so that being said, I will start with our first hosts, being Pilot Mathambo. Hi, Pilot, please do introduce yourself.
Thank you very much, Dumiso. My name is Pilot Mathambo. I work for the Pilot Mathambo Center for Men's Health, which is an organization that works for or stands for the rights of sexual minorities, especially MSM and male sex workers.
Thank you so much, Pilot. Oh, go ahead.
No, thank you.
Okay. Thank you, Pilot. Kemelo?
Thank you so much for having me, Dumi. My name is Kemelo Zotemozila. I'm a nurse midwife by profession. I'm also a founder and director at Women in Solidarity organization. It's a non-governmental organization. I'm also a director at Miss Plus World. Also, Miss Plus Africa Botswana is a patient. Former chairperson at Success Capital NGO. Thank you.
Thank you so much, Kemelo. Ruth?
Hi. Good afternoon. My name is Ruth Gidigilwe. I'm a journalist trained and professionally, but I have since moved from mainstream journalism to more media advocacy. And I specialize in human rights. I have an organization called Relay Media Communications, where we basically do advocacy media work for the civil society organizations in Botswana and Southern Africa.
Great.
Thank you.
Thank you so much. Such diverse perspectives, media, health practitioner in the public health system, and obviously civil society. And so that being said, I will open the floor for Pilot to set the scene for us and just sharing what are some of the realities for your constituents, and more importantly, what does it mean in trying to fulfill the right to health for your communities?
Thank you very much, Dumi. First of all, I would like to mention that the communities that we serve, and we are a community-led organization. So we work with sex workers and male sex workers and men who have sex with other men, but with the true realities of day-to-day working with these communities, you find that we are still very afar when it comes to or when we are talking issues of universal health coverage, because being MSM on its own or being a sex worker on its own, it's still regarded as a no-go area of discussion, and especially for male sex workers, it's more like it's a taboo for them to do that. So on that note on its own, it hinders them to access the service and to access the full service that they would require based on the needs that they would have to explain themselves to the service providers or the healthcare systems.
Thank you, Pilot. And so the second element, I guess, because you mentioned stigma, obviously discrimination, and I guess to a certain level, autonomy in itself, right? In being able to not only present many issues that would be distinct to either being MSM or being a sex worker, but also the shortcoming in intersectionality, right? Because we know programming doesn't allow for the full spectrum of our humanity to be acknowledged when trying to seek health services. I guess maybe then the one follow-up question would be, what then do you think is a significant shortcoming when an MSM who happens to be a sex worker now needs to access services, and maybe their profession is obviously not necessarily restricted by a health practitioner?
I would say with the intersectionalities, for example, availability of condoms and lube, it's currently a challenge. You'd find that the condoms, yes, they are available, but not always available. Not you cannot in a setting like where I am, you cannot go up at night and go to the clinic and access condoms. You'd find that the clinic is closed and they can only come tomorrow. Or in terms of being an MSM and being also a sex worker, it's very difficult for you because there's a bit of rationing of condoms that happens within the healthcare system. You'd find that you'd want to get a box of 100 so that you know that you could actually do your work properly with having enough condoms, not having back and forth going to the clinic to collect. But you have to explain yourself. You have to justify yourself. Why do you need 100 box? Why do you need a box of 100 of condoms? But I think that one needs to it needs to be looked into and discussed to say, let's give the people when they need the service as they need the service, and move from providing a general holistic service to be a client-driven service provision.
Thank you so much, Pilot. And I think, some of the issues we've seen on media, right, where there are shortages, commodities, medicines, we've seen where there's, lack of infrastructure in some instances. And we've seen, instances where nurses are getting opportunities outside the country. And so I'm going to bring in Ruth, maybe just to, also understand the landscape, because this knowledge we wouldn't know about had it not been for media, right? Media reports, or even just, having community mobilizers come back and give feedback, but we wouldn't know at how it impacts at a state level or countrywide had it not been for the role that media plays. And so I guess maybe the question really to Ruth is asking, to what extent is media an ally towards not only raising some of these issues, but maybe helping push the interests of different constituents like MSM or different rights holders, marginalized groups, in trying to help them fulfill the right to health. Ruth?
Yes, I'm here. Media is a huge and important ally in this avenue, in the sense that all government initiatives regarding the Ministry of Health and Wellness are propagated by the media. We put it out there. We let people know that vaccinations are going on. We let people know that PrEP is available for everybody, PEP is available for everybody, etc. in the emergency pills and all of that. My biggest concern for me, as I've been doing the work for over the years, has been like a blanket approach to healthcare problems. In as much as government saw fit for districts to be further subdivided into smaller districts, like breaking down the central district as an example. Now we have the Bubirwa district standing on its own, not being a sub-district of the central district. I hope to see it trickle into other government avenues in terms of health. Like, for example, the challenges that health workers have in Khanzi wouldn't be the same as the challenges that health workers have in Bubono. And I'd like to see different DHMTs getting together, knocking their heads, seeing how to best serve their constituents, looking at the population, the demography, the key populations in that area, and how best they can render their services to them, given their proximity and the availability of resources. Because this one glove fits all um current situation thing that we have, it doesn't work. People don't go and seek healthcare. If it's a remote area where people primarily live in the lands away from their health posts and clinics, if it means government spending money, providing vehicles for health workers to go into these settlements, to go to the farms and the lands, to give people access to their health, we need to be doing that in order to attain universal health coverage. I mean, we can't be looking good on paper, but in practicality and reality, people are not getting what they deserve and what has been set out to them. Like the budget will tell you that the money is allocated to the different ministries as well as the Ministry of Health and Wellness, but are the people getting the services they need? And another part of the media, another role of the media, of course, is to highlight the plight of nurses and why they're leaving, and encourage government to say, okay, people are leaving because of A, B, and C. What can you do to make them stay? Because we can't afford to be training and training and training practitioners only to have them go and serve other people. But then again, we can't expect them to be around without benefiting anything from their hard work. Should I stop there for now?
Thank you so
Okay,
much. I think, yeah, it's, and you've mentioned so many different, points, which I think are very, very important and what has emerged. And I think, just trying to pick with what emerged from the Delimitation Committee or Commission, sorry. And then also acknowledging the fact that, there was supposed to be, an NDP 12, if I'm not mistaken. And then that now we're in a transition, I guess, period, waiting for, the actual final 12th NDP. And then also there was a constitutional review. And so I think the question really is, how can, aside from that allyship and that solidarity, how can we strengthen accountability so that even civil society can be able to also, be like, hey, but it's not okay. There've been these promises that have been made, and we've just seen all these different reports, like we saw during the pandemic, like we saw, with some of them, the things that were being said. But in reality, we understood, we could see people had to turn to pharmacies, private sector pharmacies, and not even from state facilities. And so how can we do you think there is an avenue or there's an opportunity, be it through media or in partnership with media, and maybe what that could possibly look like, to ensure that there is accountability for some of these promises? Because there are promises being made in Geneva, in New York, and maybe not all of us are there, so not all of us can have that information. And even when the information is there, we get certain statements, and that seems to hold. And it looks like there isn't any room for us to sit there and be like, hey, no, that's not correct. Our communities are way behind. Ruth?
Thank you. Yes, like I said, our country is notoriously good for looking good on paper. Like, we sign all the agreements and the treaties. Do they still use the word treaties? We sign all of those agreements. For example, I think the Maputo Protocol and Action is 20 years old. Do we see the constitution being bended for the recommendations which were made by the ministers of health then? No, we don't. And there's a lot of complacency for me, because the reports given on the constitutional review, like the findings, Botswana were very unhappy with it, if you remember the backlash. They were very unhappy in that they felt it didn't reflect on what they felt. For me, it was a question of, were you a part of it? Did you go to the Khotla meetings? And then there was also a part of, are the Khotla meetings effective? Are they ineffective? Like, is it should just we all convene at Khotlas at this time and age? Are we not leaving out important voices who are in offices from 9 to 5? And then the Khotla meeting is from 8 to 12. Are we not opening it up to a certain group of people who share certain sentiments and the other voices are left out? You understand? Media and accountability. You see, it comes to the question of editorial policies of different media houses. Health coverage with respect to media coverage is currently not a priority. It takes things like HIV pandemics and COVID-19 pandemics to make the coverage a priority. As long as we're talking human rights, key populations, marginalized communities, your editor will ask you, like, where's the money in this? At the end of the day, the money-making industry. So what we try to do, we as the media personnel in the advocacy space, is try to encourage as many organizations to train journalists, for one, to generate interest in covering issues of health, to make them conversant with issues, to be able to get into, to make meaningful contributions in conversations like this. Because you see a lot of journalists are discouraged from health reporting, because it's relegated. I like to say they're relegated to the pink ghettos. Like, it's not important. They're used as fillers, unless we train our journalists to make them newsworthy, to craft stories in such a way that they make them newsworthy. You understand? So I think we need to form strategic alliances between journalists and the civil society, and of course all other relevant stakeholders, so that we can train them, so that we have journalists who go to New York for the CSW to go and make meaningful contributions and learn about the state of women in the world, not to go on holiday because they've been handpicked because they are a woman in a male-dominated newsroom. You understand? Usually when I do trainings, especially when I train journalists, I do a call for applications. And for you to be enrolled in my training, wherever it is in the country or in SADC, usually our trainings convene in Cape Town. You show cause why you should be a part of that training, either by providing articles that you've published before, or giving an essay of an intention of what you plan to do with the information that you're gonna learn. So the media space still has a lot of grooming to be done. Currently, as it is, there are very few journalists who can be a part of this panel and make an actual meaningful contribution to it regarding UHC. I think I've spoken too much.
No, thank you so much, Ruth. I mean, it's very, very insightful, and I think it's going to lead to, my question with Gemelo. Because Gemelo, I think one of the most important things in recognizing some of these issues and these gaps is that, to some extent, and Ruth actually did allude to some of those issues, in that, yes, we know that they're very limited resources, and sometimes when there's like a big procurement, like there were ambulances that were purchased, we know that in some regions or sub-districts, we know that, for instance, one nurse has to attend, 7 remote locations, 7 remote villages, right? And so how then in that space are you able to ensure that, you're fulfilling, never mind universal health coverage, but primary health care? How do we get the most basic of health, needs? And so as a health practitioner, I'm really curious, with all these different commitments that will be made, right? Wherever it is, in Geneva, in the Gambia, and Rona, we're coming back and we then find out what, basadi ba ko Chukumuchu are hearing it, they're saying a different story, and we now even see with certain kids, they're not obviously included in certain ways. When Ruth was sharing the example, it's also sitting there and saying, but we know full well, women have to wear dresses. And so what does that then mean, about trans individuals, And so just even going back to what Pilot had been alluding, how do you think, right, within the environment that you work on a daily basis, how inclusive is it? So I think we've all heard what it's not exactly inclusive. Mewana, from your perspective, right, and knowing full well, in terms of you and your colleagues and what you go through every single day, do you feel like it's really inclusive? So not only just, where clients are received, but how do we in terms of standard operating procedures, processes, and how do we get the primary healthcare package, in terms of basic healthcare? Do you feel like a sex worker who happens to be trans can actually receive, and get service kodonga in the same way as someone go Palapi?
I think a lot of elements have been, thank you to me. Well, I think a lot of elements have been outlined from the conversation already. And I will not shy away to say, indeed, there are challenges that exist even among us as health workers, because one, the main thing is knowledge. The second one is skill. The third one will be your personal, let me say maybe each and every region. For example, you go to, let me say you go to Wibira, you'll find that culturally, this is an area, let me say maybe Topong, we very know that Topong is very rooted in their ancestral beliefs and so forth. So you go to another region that is very strongly rooted and that believes is in Christianity. So as a health worker, sometimes when you go into those areas, you are automatically supposed to be culturally sensitive to their beliefs, to their whatever, so that you can help the community very well. So when it comes to issues of sexuality, especially when you say sex workers, transgender, and everything, I would say it becomes a personal matter again. It becomes a choice or a personal matter also with the health worker to say, now you are to decide whether to allow a sex worker, or let me say a transgender, to come into the Kotla meeting and allow them to wearing the same or whatever they're comfortable in. You understand? It becomes a bit of, let me say, what you call it, now it has to be a decision that has to be made by an individual. But now that we are talking about universal health for all, we're talking about the right, the human right, which says the right for all. Now, when we get to that point, then it automatically, as a health worker, we have to consider even the rights of the other individual, the next person, to say, is this information important for them? Are they in the right place? Should they the kind of information that will be shared, or the services that are shared, are they important, or is the person supposed to be in that area? Well, it comes with a lot of challenges. It basically comes with a lot of challenges. But when you talk about the communities, different communities that exist in our country, and also the delivery of health services by the health workers, it still remains a challenge. That one I will not run away from. It still remains a greater challenge. One of the main things being knowledge, because let me outline that for me as a person to have known more or have a better understanding of dealing with other communities is when I started joining the civil societies. Apart from that, while I was still in the hospital working alone as a midwife, I did not know about these things. And hear me, I'm a midwife and I deliver patients on a daily basis. I meet different kinds. I meet the transgenders, I meet lesbians who are pregnant, and I mean, it's their choice at the end of the day. How they choose to deliver babies is their choice. And it's something that remains unquestionable for me. And my duty or my role at that point is to help the customer and make sure that they are okay, they are safe, and they leave the delivery room or even the commodities, because I'm also a consultant. Like, I make sure that we give out the commodities, FP and everything. When someone comes into the room to say, I'm here to ask for condoms, it's not if it's a sex worker or it's a lesbian, it's a gay, it's not my position. It's not what you call it to me.
Well, it comes naturally to you, but I think you've shared it. You've highlighted, and what you've mentioned also is, it's also, when you mention the personal, and I think a lot of us don't ever tackle these issues, is that we mask it behind no, it must be cultural beliefs, it must be religious beliefs, but the reality is that this is really personal, right? The personal coming into the professional, and like you're saying, and I can imagine there are intergenerational gaps, right, where there are more elderly health providers that might then, they were always giving the same kinds of response, especially when criminalization was still a huge component, because they'd say, no, it's against the law, and so forth, and so they had all those reasons. So when you say personal, I'm even reminded about, the Khosi that would sit there and say, no, at a personal level, right, in the community. But then what does that mean? Right? And so I guess for me, then the question is, Gemelo, how in that situation does a rights holder, does a community member, or even let's say someone who would be considered underage, because I guess you need certain permission if you need to be a certain age for you to get an HIV test. So what does that mean for that young individual who, one, maybe batsadi are very absent, right? Or batsadi are not, really engaged in that child's life. Or batsadi are very strict, and meanwhile this child actually needs to get who knows, an abortion, so to speak, right? So, but let's just stick to the same basic horror. At the end of the day, or let's say maybe there might be defilement and there's a need for an HIV test, and parents are unreachable. What in that context, how does then someone assert their rights to say, but it is my right for me to know about my health status. It is my right, after having gone through an atrocity, I need to make sure I can access PEP, right? So how can we make sure, even at that micro level, there can be accountability?
What we do here, let me speak for my setting here in the hospital. When an underage, let me say when a minor, because we call them minors, when a minor comes and they're in need of health, we assess the situation. We look at the child to say, is this an emergency? If it is an emergency situation, we make sure that we consent as health workers. Maybe 2 doctors will consent for that child and help her. For example, maybe in an absence of parents, and then the child have to go for a cesarean section. We consent for that child. We don't wait, because there is a matter of life and death. But when you talk about where the child needs to know about the HIV status, I think a lot of elements will have to be looked at in, and also there have to be engagement of other stakeholders like the social worker, so that the child at the end of the day can be assisted. Yes.
Thank you so much, Kamala. And I think, this is very important. And maybe, back to you, Pilot, in terms of just some of these gaps, is that obviously we see them. There's a reason why maybe you find community health referral systems are there, that helped, to bridge and sort of counteract some of these stigma, or the questions that are around, maybe the social determinants to accessing universal health coverage. But I think, Pilot, Kamala just alluded to it, where, there'll be pregnant lesbians. And we already know, as a standard care package, no one will ever sit there and consider, maybe the reality is that they would have assumed lesbian, they would never be pregnant. So they would have never been referred to, somewhere. And I think what we found out in the Okavango region, we found out that there are some locations where the STIs are bacterial, so they're not viral, because or they don't wash, right? Or it's not part of, it's inherently within ethnic minority or certain cultures to not necessarily always be washing. So I think the question then now is, Pilot, with all these different distinct issues, what would you say, or how can we guarantee universal health coverage, acknowledging yes, districts have been divided even further, right? But then there are very unique issues that are there. How do we not compromise the quality, the inclusion, and I guess to a large extent, the intent, the professionalism of care services, across the country. How can we do that? I can access the same kind of service as I can access Hakeloko Jane or Hakeloko Maunga, where there's more business there. Pilot? Just unmute yourself, Pilot.
Thank you very much, Dumi, for the question. I would say, generally, the bureaucracy and the model that have been used, or most of the time being used, you find that these are top-down models, where the information comes, let's say, for example, for the ministerial level, the PS, then the directors, then it takes time and the information gets there. I think we need new strategies where we could run parallel programmings or sense of information dissemination where it will also start from the grassroots going up, so that it could be used as well as to capture data, to collect data to say, how well do the people understand this? I mean, for example, for the issue that we are actually talking, even as civil society today, we don't fully understand what universal health coverage means. Somebody would tell you something totally different according to that context. But we need a standardized way of trickling this information down and top down, so that we can both be at a level where to a mere lay nurse in a rural area could actually understand what it means and be able to provide the service to the needful or to the communities, or regardless of being a minority, regardless of just being a mere citizen.
And so I think then the question would be, Pilot, in that regard, because information is power, I get. I think we've seen so many instances where even when there is that level of knowledge, I know this community, we go out together. But the reality is that there aren't enough resources, or there isn't enough delegated authority, or they don't have the power and the means to accommodate those issues. So in that context, then what does it mean?
Civil society is there. It's there to support the government where the government to meet the government, or to help the government where the government is not able to reach. I would say, Dumi, it's very in the open to say civil society have been profound to actually provide service and deliver at a faster rate than the government. And I think the government also should benchmark a lot of its work, or whatever service that they're doing, from the civil society, or we do a collaboration or hand in hand, or long-term partnerships with the government to say, because these are the issues, and currently you guys have been doing and being the best practice, how long can we really actually make these things happen together, working together and in partnerships?
Mm. And then maybe more importantly, what would you suggest as even for community members? Because I get accountability is not just reliant on civil society. It's not just reliant on media. So what does it mean for the client themselves? Habasaboni services, proper services or care, or if they experience discrimination, what would you suggest as an avenue of making sure that they can strengthen this?
We need to build strong community movements and strong community systems monitoring, so that the communities, they need to know their rights. First of all, they need to be assertive enough to be able to claim their rights and identify the violations. Then we need to build movements from the grassroots and on the ground, so that they know their rights and how to access and assert themselves to be able to claim or access their rights. I mean, from today, you'd find that we have communities, because they've been stigmatized and they've been discriminated against, they self-stigma themselves to a point where they think, or they don't, or they shy away from accessing service just because they don't access the service, just because, now they think the services are not there, while the services are available there sometimes.
Thank you, Pilot. And so now I'm going to shift gears a little bit, just in case there might be any thought-provoking questions or queries based on what you've been hearing from each other. I will open up the floor and just take, a round of comments or questions, to one of the other panelists. If you have any, then please, this is the opportunity for that before we then go into the top 3 recommendations and close. So I will open up, maybe ask Ruth if there might be any questions to your, fellow panelists. And if there's any insights or commentary that you might have felt like, oh goodness, this is something that would have been, good to just build on or even critique.
Thank you very much. Thank you guys for the commentary. It's amazing. Ms. Kenelo, you're doing an amazing job. I was very touched at how you react to the situations where you work in your workplace. I'd like to lament, for the lack of a better word, on Pilot's assertions regarding community like uniting communities. Where I am right now, we are trying to convene banna ke mo segope ga utlwa ke nna ke ira di-references tsa bo bonong bodira yana. We're trying to convene banna ba community ya rona to get together to be able to talk to each other about social issues, to be able to have a place to go to, a safe space for men, for them to be men without being judged on societal expectations like men don't cry. We want a space where men are able to call each other out and say, hey, Patrick, that girl I saw you with yesterday is underage. You need to stop it. I will report you. I mean, it all starts at community level for them to be able to talk to each other like that, for them to be able to find a safe space for them to be themselves. Let's say they had a fight with the missus, for them to be able to go there instead of resorting to violence. For me, it's a positive step in terms of addressing gender-based violence while involving the men without necessarily tailor-making it for empowering women and ending there. So I think involving the community at large to address any problems or social ills or whatever is a very important factor that needs to be considered when making programs and interventions for whatever situations that we may find ourselves in. I think for now that's all I can say.
Wait, thank you, Ruth. Camelo? You unmute, my gal. Yes.
Oh, thank you. Today we're discussing universal health for all, and coverage, and it just hits hard to come to terms of the fact that I think if maybe in 2000 or in 2015, as a country, we had made some steps towards the goals that are very achievable. Ever since the COVID pandemic, we are declining. It's very sad for me to mention it because I don't know what is in paper, like Ruth has outlined, but what is happening on the ground is a total disaster. The fact that we are out of medicines, there's lack of procurement of obvious reasons that we see on media and that we actually not sure of. The situation has become even more worse because as much as we are talking about primary healthcare and delivery of services by healthcare workers, the situation has become worse because now we are even losing even the skilled care workers, the personnel. The country has lost a large number and is still yet to lose more. And I'm surprised to hear the other day, I don't know if Ruth would second me on this, that WHO had consulted with the country to say, are we in lack of healthcare workers? What is happening? What is the situation in Botswana? And the response from the country was that no, the country is okay. When so many countries were put on red list, so that Western countries cannot come and fetch workers from here, Botswana remained open. That is to say, we are still yet to lose more and more people. And the minority of healthcare workers that remain on the ground, it becomes even more impossible and hard for them to execute and practice effectively as they are supposed to, according to the standard of procedures, because of the demands or the number of community members that they're supposed to help, because one healthcare worker cannot do each and everything in their facility to all, or even to 10. It's quite a large number for them to achieve. So I don't know where we stand now. We are having these conversations today, and I think I don't know where we stand as a country and where we are going and what exactly is best that we can do. But like Pilot had mentioned or had said earlier, that a better involvement of CSOs could probably be one of the solutions. The reason why I'm saying that is because earlier on I had mentioned that as a healthcare worker, as a midwife, who also dispenses healthcare commodities, FP commodities to the community, I wasn't aware of so many things until I joined the CSO. And allow me to say this, that until I became part of the Success Capital, the conferences, the workshops that were held, and this kind of conversations that I was exposed to through the CSO, that's when my mind was open to say, okay, we are having these challenges, we have this in our community. And therefore, I even had a better approach to my customers as they come in. But how about someone who still remains at that level where I was before I joined?
So maybe the question to ask, Gemelo, is maybe, okay, let's acknowledge what Botswana as a higher middle income country means that civil society organizations are not able to get enough resources. We also know what resourcing as a country, even government can help, whether it's social contracting or to actually end up giving, civil society. It's not always universal. It's not always equitable. So in that context, it obviously means that there are some limitations how civil society can access some places. You see, like how when Ruth was sharing, I was sitting there and asking myself, hey, Lan, Kante, is that actually a district that's covered whether by the Global Fund? Is it covered by PEPFAR? And I'm sitting trying to figure out where would money be coming from, to help, in making this a reality, because the reality is that a lot of these initiatives are taken because, people are really affected and they then go off and try do it, whether the budget is there or not, right? And to some extent, yes, a budget will sit there and say, well, no, you are having an HIV workshop. And then you then sit there and you see but we need to now have conversations around SRHR, conversations around bodily autonomy and integrity, because there's so many other things. So given that conundrum, let me say, what would you say, Gemelo, because I understand there can be a lot of exhaustion, someone is stretched, you have to provide counseling, you have to provide testing services, and if someone's not available, you're helping with cervical cancer screening, and so, so you're filling in other gaps as well, and to some extent, even sometimes when you're helping for another colleague that's not there. So I think my question really is, surely the trigger point for new knowledge can't be a workshop, right? Surely a trigger point can't be just because so what is it? Because and I think it's helpful, yes, that someone can have a newspaper and then see oh my goodness, there's GBV, but GBV also impacts UHC, right? Or there's climate change also impacts universal health coverage, because it might mean less budget, it might mean for some people in some locations, when there's a disaster, then that means there's no services at all, so the question then comes to say, so understanding what the situation is like that, and a lot of community members don't have the power. Already, when someone is sick, they will only go when they're in their worst condition, at the latest stage, and we know it will already be bad by then. So how can we try, in some way, for a health practitioner to then, does that mean they Google a little bit more when they read an article? Does it mean that they should encourage their superiors to say, we need more trainings, can you avail the funding, or can you bring in the CSO so that they can train us? What would help without us having to without having a directive imposed on staff? What would help for people to be socialized with their communities? Because even if someone takes a transfer from Gaborone, aya right, or aya Sihipa, there are cultural issues that they won't be aware of and that they will be forced to start adapting to. So what do you think is needed, without someone having to, okay, I'm a good person, let me try to do a little bit more for my community. But how do we make that business as usual? How do we normalize, health practitioners being socialized or being alive to their situation, their surroundings, and the people who are around them? And this is key because it's not just health workers. We know it's the same situation in Gama Police, with police officers. We know it's the same position with other government departments, even social workers. So, but at least we know, because of the right to health and the advancements and gains that have been made in health, in including vulnerable communities, there can be an answer somewhere there that can help us unlock even these other sectors within the public sector. Gemelo?
Yes, to me, you've touched on a lot of issues. One of the things being, how can we make sure that there's education to these health workers? How can we make sure that there's equity of resources, especially in these regions? And then let me tell you, because as a man who stands on the ground, especially here, I think I remain powerless, especially to some decisions when it comes to decision making, especially when you talk about resources and changing of the system and transfers as to Gemelo being the midwife, being socially connected to her community, being very functional, and now being transferred to the full pay, and then Francistown remains suffering and stuff. Now this goes back to the policymakers, because it comes as a directive for us. You are told what to do and what not to do. And so if you are on the ground, it becomes very, very, very hard. Even if you are out of paracetamol, we can question, but at the end of the day, I cannot go and make sure that there's procurement of paracetamol. I can always report back to say, we don't have paracetamol, but we really need paracetamol in our community, because we have so and so many people who are cancer patients, who are diabetic patients, who are, you understand, can even run off the most important medication that is needed as of what is happening currently. People have to, our parents, especially those suffering from chronic illnesses, they have to go and make sure that they buy from chemists and stuff. You are told there's nothing, and that's where it ends. For a health worker who's very socially connected to your community, very well that I'm treating this client and they don't have resources, they don't have money. Even if I send them back to say, go and get this medication for yourself, they cannot afford, and you are helpless in that state. We remain very, very, very helpless and powerless in a lot of situations, especially for us who are on the ground, because in our country, a lot of decisions are made from above. You understand?
Thank you so much, Gemelo. And it's quite heartbreaking. And I must then bring in Pilot. And I know this is just really the open session, but really to say, Pilot, even when as civil society, we've just been hearing some of the gaps, and we know what a civil society usually, especially in other countries, are able to call out and instill some change. And we've already seen it happen in Botswana in very few instances. And we've seen it even in strategic litigation and so many other things in making sure that there's some element of the right to health, even though it's not a guarantee in Botswana. But to what Gemelo is saying, my question to you, Pilot, is with some of the experiences you've had over time, how best can we then engage policymakers to not only meaningfully accommodate, like you mentioned, bottom up, but to actually then make decisions in that regard? Because I think We have given some of the workshops, in some of those, policymaker spaces. There have been parliamentary caucuses that have been sensitized, but we're still seeing political will, the commitment in terms of budget allocation to say invest in this is not there. And I will go off and even say, to a large extent, we know full well that even the resourcing landscape for media, like Ruth had even alluded, is this bringing money, right? Will people buy papers because of this? So these are important, pertinent things that I'm trying to figure out. What does it mean for us as civil society? And what does it mean we can actually do to also be allies for health practitioners and to also be allies for media practitioners? Pilot?
Thank you once again. I would say civil and civic education is important, because one to fully be able to stand up, they need to understand what is citizenry. With understanding citizenry, people will understand their rights, and they will understand what it means to be a citizen of a certain country, for example, for a citizen of Botswana. And they'll be able to demand, and they will be able to associate with the people of common issues to say, this is what we want us to be. But without that, we are currently very, very, very at a low stages where people don't even understand why they vote. It's not even important to vote. The youth will tell you, why waste time? Why would I go and waste time in the queue? So we need to understand what is citizenship, what is citizenry, what is my role as a citizen of a certain country. With that, people are and when we are at that level, that's when we'll be able to be accountable, or to take the politicians or the political will or the political leadership to account for what they say at the global level to what they say at the regional level. And we would be able to come up with structures and systems to say, this is the strategies to make our healthcare system accountable. Because you would find that there are disparities. The politicians will say one thing, and they will glorify the issues. Then you find that the government or the ministry now has to say something different. And normally you find that they would say, we are the implementers. We haven't received any official communication on certain issues. But if we have the citizens that are assertive in their issues, they will be able to take the government to task, or the government of the day to task, or the department, or the certain department, or whatever department to task, to say, this is what your mandate and your vision is saying. I'm here, I'm not actually accessing any of what you're saying in your mandate. Because now the model have changed. You'd find that, I would say maybe it's political, I would say political incline. The servant has become the master. I'm saying this because, for example, the politicians are supposed to serve the citizens. The civil servants, like the name says, they are supposed to serve the communities. But now the civil servants, most of the time, they dictate to the communities on what to do. Or sometimes they dictate their views. So I still stand to say, let's build the masses from the ground. Let the masses on the ground have knowledge. Let's have strong movements. Let's have strong movements of young people who are learned, who will be able to assist the older generation to understand the issues. Because you'd find that the people currently in power right now, or the people who are in decision-making spaces right now, they're from a different age. And they're all digital migrants. And now the knowledge, or most of the knowledge, has moved from analog to digital. And having a digital migrant, having to deal with all this oncoming information, which is in computers, it's not working for them. We need to change the models of how the information needs to be consumed.
Thank you very much, Pilot. Thank you. I think, yes, just with the last one, we will start with Gemino. What are the top 3 recommendations for us to really fulfill universal health coverage? And I will say this, I see universal health coverage as an avenue to fulfilling the right to health. So we're hoping that, whatever it is, whether it's, what are some of those recommendations that you would like to see as a health practitioner in the public sector, the top 3 things that you would suggest as key recommendations to be made towards the government?
The first of all, I would say multi-sectoral integration. That is to say, make sure that there is collaboration between the health sector, the policymakers, the community, and the civil societies, because we all come with different angles and we all understand our community from different perspectives. So if we can all sit down and reach a common goal, a consensus, then it's achievable. The second one mostly is community, not only community, it's education, distribution of information, making sure that all health workers, even the community, understand their rights, understand what is supposed to be given to them, and even understand more about even the commodities that we have as the health sector. I think that's all.
Okay, thank you so much, Camilla, with 2 recommendations. I will then give the floor to Ruth. What are your top 3 recommendations to the government?
My recommendations is to capacitate, train, and train, because in order for us as journalists to spread the word, we need to know what we're talking about. And you can't generate interest in something that you know nothing about. So we need a lot of capacity building, a lot of training, a lot of interactions, forming networks that would mutually benefit the media, the CSO, and the government. Thank you.
Thank you, Ruth, with 1 recommendation. So Pilot, please do provide your 3 recommendations. And I think you've been given a little bit of room to add if you want to add any more.
Okay. To me, the recommendation is to say, let people have knowledge on UHC. Normally the information ends at the top. Let's have strengthened civil society dialogues on universal health coverage. Not civil society which is at the top, but grassroots, because they are the ones that are dealing with the day-to-day issues. Grassroots, civil society dialogues, so they understand, so they unpack. When we talk universal health coverage for all, what do we mean? And what is it? What is universal health coverage in layman's language? Thank you.
Thank you very much for also your 1 recommendation. I think this was important dialogue, and hopefully it's the first of quite a few, not only virtually, but hopefully in person, as we're working towards having a joint country dialogue and towards the high-level meeting on universal health coverage. And so I would like to thank you all so much for your amazing insights. It has been a truly lovely, engaging, and insightful conversation, and hoping that we can can be able to move forward with some of these not only challenges, but also be able to address them through some of the recommendations that you have made. And so that being said, thank you once again. A luta continua.
Thank you.